All right, first I want to thank everyone here for making it here today in this weather, and especially I want to thank everyone here for the training that you've given me throughout the past 4.5 years. I feel especially privileged to be talking about something that I feel passionate about, which is ultrasound. Ultrasound for me, I feel, has made me a better surgeon, and today I'm going to be talking about ultrasound for the general surgeon from the bedside to the operating room. As far as disclosures, unfortunately, I have nothing to disclose. I don't hold any stock in any ultrasound company. Sinai doesn't have me in their pocket, or Mindray, or any of these other companies. So I do have some goals for this talk that we can go over. First of all, I want to discuss the applications that we as general surgeons can use ultrasound for. Furthermore, I want to describe the characteristics of the common studies that the general surgeon can perform. And finally, go over some of the evidence for general surgeon performed ultrasound. And I hope by the end of this talk, I've convinced some of you that ultrasound should be part of the armamentarium of the general surgeon. So briefly, let's just go over some history. Where did ultrasound begin? Medical ultrasonography has its beginning roots with sonar developed in World War I. The first written reports of ultrasound describing abdominal disease were described in 1958, and shortly thereafter it was taken up by cardiology, radiology, and obstetrics in the following decades. The use of bedside ultrasound really wasn't used until the mid-1990s, when ultrasound became more compact and more affordable. Briefly, I want to just mention how the image we see on the screen is created. So you have a transducer, and it creates an image, or it creates a wave. It bounces off an object, and these echoes are reflected back, and they're picked up by the machine and shown as a digital image. Simply put, these are echoes that are created to show an image. The thing that's important to note is that high-frequency ultrasound has lower penetration, but a higher resolution. A low-frequency ultrasound has a higher penetration, but a lower resolution. So what does this mean? If you're going to examine an abdominal compartment, you're going to want to use a low-frequency probe, such as this curvilinear probe with a frequency of about 2 to 5 megahertz. If you're going to image more superficial substructures, such as the vasculature or the neck, you're going to use the linear probe, which has a higher frequency. So let's continue on. If you were to ask me what I thought about ultrasound 5 years ago, this is what would have come to my mind. You know, maybe this is because my mom is an OB-GYN, but this is the image I would have thought of. But I think it's actually because I was unaware of the clinical applications that we can use for ultrasound. Similarly, if you would have asked me what my tools of diagnosis were 5 years ago, I would have thought of these things: a stethoscope, maybe a reflex hammer, this other thing, I don't know how to pronounce it. Okay, but now there's ultrasound. I don't know if you're aware, but the first-year students at Mount Sinai are given these GE V-scans, and it's part of their medical school curriculum to learn how to use and interpret the imaging. So what is the implication of this for us? I think that it means that the next generation of physicians are going to be able to use these and interpret bedside imaging, so it behooves us to understand ultrasound. Finally, I want to basically show that the ultrasound can be an extension of our physical exam. And it's not really to be taken lightly. It takes practice to become a master of ultrasound, kind of like this guy. But actually, I'm just joking. You know, I still think of myself as a work in progress, and I try to scan as much as possible. So some of you are sitting there thinking about surgeons and ultrasound. Why are we talking about this? You know, ultrasound, that's radiologists. Surgeons, we do surgery. This is just hocus pocus. Why are we talking about this? Really, it's just pocus. This is point-of-care ultrasound. The point-of-care ultrasound is focused ultrasonography performed by the surgeon at bedside, and it helps you decide what you're going to do with your patient. So just looking at the literature, if you just do a literature search on surgeon-performed ultrasound, and you can see that there's a stark increase from the 1990s to the present day with increasing data showing the validity of these studies done by the surgeon. So does the surgeon need to learn this? The ACS seems to think so. They offer multiple courses on their website, starting from a basic course, an ultrasound for residents course, which goes over instrumentation, the physics, also introduction to vascular, abdominal, thoracic, also a course in FAST and focused ICU and echo applications for the critical care patient, as well as thyroid and parathyroid ultrasound, focusing on the office diagnosis of parathyroid and thyroid disease. But I came up with a slightly larger list of things that I've seen ultrasound used throughout my 5 years. And this is a pretty vast list of things that you can look at ultrasound can be used for diagnosis. But today, I've highlighted the ones in red as ones that I'd like to go over and review that are definitely in the general surgeon's armamentarium. Now, to do a complete overview of all of these is out of the scope of this talk, but I want to show the importance of ultrasound in these specific situations. So in doing this, I actually did a little poll of our own residents to see what their thoughts were on ultrasound and their ability to perform ultrasound. Looking at it, about 60% of our residents don't perform bedside ultrasound because they don't really feel proficient at doing it. 75% feel comfortable with ultrasound for vascular access. 55% feel comfortable performing the FAST exam. Although this is acceptable, I think this leaves some room for improvement. On a side note, thank you to all the residents for filling out the survey, especially someone for these kind words. I wonder who that could have been. Fine. So, in talking about the surgeon and the use of ultrasound, you definitely actually have to think of the vascular surgeon. Not only may they be better looking than us, but they're actually more adept and more proficient with the use of ultrasound. In fact, their training now includes vascular lab experience and obtaining RPVI certification, in which you have to get specific educational and professional requirements before applying and complete over 500 scans. So on that note, I would like to begin with vascular access as a starting point in discussing the general surgeon's use of ultrasound. So we're all familiar with these devices here. There's a portic cath, there's a triple lumen, a vascular access sheath, a Broviac or Hickman catheter. And we're all using these. And I believe it's actually now standard of care whenever you're instrumenting the artery or vein to use ultrasound. But don't take my word for it. The ACS has put into writing on their statement about the recommendations for use of real-time ultrasound in central venous catheter insertion. I won't make you read this whole thing. I'll summarize it for you. In this statement, they support the use of real-time ultrasound guidance for the placement of catheters into the central venous system. Also, in 2001, the Agency for Healthcare Research and Quality recommended the use of ultrasound guidance for the placement of central venous catheters as one of the top 11 evidence-based practices that healthcare providers can use to improve patient care and patient safety. This went along with such things as washing your hands and performing a surgical checklist. So let's continue. What are the techniques that we use for ultrasound-guided access? Here I'm showing a short access technique. This is the technique that's probably used by most beginners. And in fact, the way I learned how to use ultrasound the first time in my first month here at Mount Sinai in the SICU. It's important to note in doing this that you have to be cognizant of where your needle is. You may even have to follow the needle out as it continues forward, as you may lose it, as this is shown in this example. So let's see what this looks like. So here you can see the IJ, the adjacent carotid. As you begin to place your needle, you see its hyperechoic needle tip starting to tent the anterior wall of the vessel. As you continue forward, you see further tenting of the vessel until finally you see release. and the needle is within the lumen, and you're ready to place your sheath, or you're ready to place your wire. So let's look at this in real time. You're introducing the needle perpendicular. You can see in the ultrasound image accompanying, as you enter, you get flash. Very simple, short axis technique that we all should be familiar with. So is there another way to do this? Yep, there's the long axis technique. This is another technique for puncture. It's called long axis or longitudinal axis approach. And this is done by placing the needle parallel to the probe. And this one has actually been associated with being better able to visualize the whole needle along its entire course. And there's actually been recent literature saying that this may actually increase first pass success. So what does this look like on ultrasound? Here you can see the whole needle along its entire course, and you can actually visualize it as the tip enters the vessel. So what does this look like in real time? Here you go. You can see the needle being introduced and flashback as it enters the anterior wall of the vessel. And you can follow the needle the whole way. So the evidence definitely supports the use of real-time ultrasound for central venous access. In a meta-analysis from 2003, there were 68 failures in 312 patients when just using the landmark method. When using ultrasound, there were 5 failures in 296 patients. This led to a 0.14 relative risk for using ultrasound, which correlates to a relative risk reduction of 86%. Furthermore, in this study, it showed a 57% relative risk reduction for all complications with the use of ultrasound. The use of ultrasound is not just accepted in venous access punctures, but also in arterial access. This is a multi-center randomized controlled trial of 1,002 patients looking at ultrasound guidance versus fluoroscopy for femoral arterial access. And looking at this, ultrasound was associated with an overall reduced number of attempts at access at 1.3 versus 3, and an increased first pass success at 82% versus 46%, and an overall reduced rate of complications at 1.4% versus 3.4%. Finally, in going over the data more, I looked at the pediatric literature as well because it looked like it wasn't accepted as much in the pediatric literature early on. In this recent article from the American College of Surgeons that compared ultrasound to the landmark method in pediatric patients, it again shows the findings we're seeing in the adult literature. A 65% first to pass attempt as opposed to 45% with the landmark method. And then success within the first 3 attempts showed a 95% as opposed to 74%. So basically, with the evidence supporting the fact that ultrasound is superior to the landmark method, it rests with us to practice evidence-based techniques and perform our vascular access with ultrasound. Why would you perform anything blind, basically? And I think this depicts it well here. So now let's move on. Let's talk about another study that we've adopted as surgeons and we can discuss today. And this is in trauma. So ultrasound was first used in the evaluation of trauma in Europe. They're always ahead of us in everything, basically. This started in the 1970s. And indeed, the General Surgery Board in Germany has required certification of ultrasound skills for their surgeons since 1988. Since about the mid-1980s in America, we began using ultrasound for trauma. And indeed, it has all but replaced the DPL. And then FAST has been included in ATLS training since 1997. So what are the views we're looking at in the FAST? We're looking at the right upper quadrant, we're looking at the left upper quadrant, we're looking in the pelvis, and we're looking at a subxiphoid view. Things we should all be familiar with. So let's go. Let's look at the right upper quadrant view. This is done in the mid-axillary line at about the level of the 7th or 8th intercostal space. You're looking at the area between the kidney and the liver. Here you can see the kidney, here you can see the liver, and the hyperechoic line. This is a negative study. It's important to note about 200 to 250 cc's is required to produce a positive study. Go back one. Here again, this is a still image, again showing a negative study. You have the kidney, you have the liver, you have a hyperechoic region here. This is the diaphragm above. This area, this space right here in Morrison's pouch is where you're looking for fluid to accumulate, and here's the CT scan that correlates with that. So here's a subtly positive FAST exam. You can see a hypoechoic fluid attenuation in between the kidney and the liver. So let's shift gears. Let's move up to the left upper quadrant, or the splenorenal recess. The propositioning of this is similar to the right upper quadrant, except it may have to be placed more cephalad and more posteriorly, as this is the location of this recess. It's also important to note, here's your kidney, here's your spleen, here's the hyperechoic line between them. It's also important to look at the area between the spleen and the diaphragm, as this may be the first place where fluid may collect. So again, looking at a still image here, you can see the left kidney, the spleen, the diaphragm, and no fluid seen between the two. This is a negative study, and this is the accompanying CT scan. So let's look at a positive study. Here you see the kidney and spleen, large amount of fluid here, and also looking above the spleen, between the spleen and diaphragm, you can see the fluid tracking up here as well. Finally, continuing on, looking at the pelvis, this is looked at in transverse imaging here. You can see a negative study showing nothing behind the bladder. It's often good to do this before the placement of a Foley catheter. Here we're looking at a sagittal view. It's important to look at the pelvic views in both axial and sagittal imaging. These are both in males and showing negative studies with nothing, no fluid seen behind the bladder. What does this look like in women? Here you can see the bladder full of fluid, the uterus, and there's no fluid seen where it would normally be collecting in a positive FAST, and here it is in sagittal imaging, the bladder and the uterus. So let's take a look at some positive studies. Here we can see the bladder, the uterus, and looking behind it, this is a positive study in a patient, in a trauma patient, with free fluid seen behind the bladder. Continuing on, this is a male pelvis now, looking at the bladder and then this large amount of fluid behind it. You can even see the loops of bowel swirling around in this large amount of fluid behind the bladder. So this is another positive FAST study in a patient that had undergone blunt abdominal trauma. Finally, the last view that we look at is the subxiphoid view. This is done by placing the probe to the right of the xiphoid, just below it, and actually beaming through the left lobe of the liver. This is the image that you'll see. The left atrium here, the left ventricle a little bit above that, and then the right atrium and right ventricle above these. So what does this look like on ultrasound? So here you can see it well. This is a subxiphoid view looking at the right atrium, left ventricle, right atrium, and the right ventricle. And this shows no fluid. This is a negative FAST study looking at the heart. So what does a positive look like? This is a positive study. This is the pericardium, a hypoattenuating fluid density seen between the myocardium and the pericardium, and this is a positive study. So how are surgeons at performing FAST exam? This is an older paper actually from 1998 out of Annals that was from the Grady Center and Memorial in Atlanta. It was done to determine the accuracy of FAST performed by the trauma team. This included 1,540 patients, 1,227 blunt and 313 penetrating precordial transthoracic injuries. The sensitivity for these patients with penetrating precordial transthoracic injuries was 100%. Looking at all comers for blunt abdominal trauma, the sensitivity was 78.3%. But if you divided this into those patients who were hypotensive on arrival, they had a sensitivity of 100% with those 30 patients. So continuing on, I think maybe some of you have heard of the EFAST, or what's called the extended FAST. Maybe you haven't. But this is basically a FAST plus exams looking for hemothorax and pneumothorax. So how is this performed? To evaluate for pneumothorax using ultrasound, you can actually place the linear probe in between the third and fourth intercostal space in the anterior chest. What does this look like? Here, we'll look at, you can see the subcutaneous tissue. You see the two adjacent ribs and their shadowing that can be seen. You see their pleural line, and you see here what's known as a comet tail artifact. This is caused by the two visceral and parietal pleura being in close contact to each other. What does this look like in real time? So here you can see this image on the left is looking at a lung, and you see with a sign what's called as lung sliding. This, along with comet tail artifact, basically almost has a 100% negative predictive value that this patient doesn't have a pneumothorax, if you see these two findings. Here, this image on the right, we see absence of lung sliding and no comet tail artifacts. So this is essentially how you perform an ultrasound looking for pneumothorax. There is another method you can use. You can put the ultrasound into IM mode. And this image on the left is a negative study. You see the subcutaneous tissue down to the pleural line, and then behind the pleural line, you see this grainy or sandy image. This is known as the waves on a beach or seashore sign. And this is caused by the movement of the lung behind the pleural line. This image on the right, again, you see the subcutaneous tissue, which is not moving, the pleural line, and then you have what's called either the barcode or stratosphere sign. And this is caused by no movement of the lung seen behind the pleural line. Also, as promised, I said that you can evaluate for hemothorax on the extended fast. This is done with your standard right upper quadrant or left upper quadrant views. And you actually have to look cephalad to the diaphragm. So the diaphragm acts as a strong reflector of ultrasound waves. And this causes an artifact in which the liver on the right side and the spleen on the left side are reflected above and create a mirror image. And that's what's normally seen. In this study, you see a hypoechoic attenuation above the diaphragm, and this is consistent in a patient with hemothorax. So what does this look like in real time? You have the liver, you have the diaphragm, and above it, you're losing its mirror image, which is usually seen. And this is pleural fluid in a patient with a hemothorax after trauma. So how good is ultrasound for diagnosing pneumothorax? This is a prospective study from a level 1 trauma center. They took 176 trauma patients. They performed an ultrasound or a supine X-ray, which is standard in all of our trauma patients, and they used CT as the gold standard. The sensitivity for chest X-ray was 75%. The sensitivity for ultrasound, 98.1%. So this was emergency medicine literature. What about us as surgeons? How good are we? This is another prospective analysis of 328 patients. Looking at the sensitivity of surgeon-performed ultrasound, we have a sensitivity of 92.3% in finding pneumothorax with a specificity of 99.6%. And this was just using lung sliding and comet tail artifact as the diagnostic criterion. So I have to admit, it actually took me a little bit to buy into the fact that ultrasound could be so good for pneumothorax, but the evidence is very strong, and it even made this guy a believer. So let's move on. Let's move out of the trauma bay. Let's go to an office-based setting. And let's start with a 35-year-old female. She's sent to you in the office. She has primary hyperparathyroidism. There's no imaging done yet. She has elevated calcium, elevated PTH, no imaging. What do you do next? So you're in your office. The next thing you do is you perform an ultrasound of the neck. This is what you see. In the right inferior sagittal view of the neck, this is the thyroid above. You see this hypoechoic soft tissue density, and this is consistent with a parathyroid adenoma. Need you do anything more, or are you done? So let's keep that in mind as we go over another scanning that should be performed by general surgeons with the thyroid and parathyroid. So here's a nice illustration of the neck anatomy. What I think is actually amazing at looking at ultrasound of the neck is how beautifully everything is visualized. In this image, you can see the thyroid, the trachea, the carotid, the jugular, the strap muscles, the sternocleidomastoid, even the C6 vertebrae. You can see everything so nicely. So to overview everything in thyroid imaging would be exhaustive and out of the scope of this talk, but I just want to review a couple of things that we should be familiar with if you're doing these images in the office. So one of them is microcalcifications, which is definitely associated with a higher increased risk of malignancy in these thyroid nodules. Here's a large nodule within the right thyroid showing microcalcifications. This next to it is actually a halo, or an eggshell halo. It's actually associated with benign thyroid nodules. Continuing on, you can also look at thyroid nodules. They have cystic components or solid components. This is actually a papillary thyroid cancer in a patient with a cystic and solid component. And within the solid component, you can see microcalcifications. Another thing that you can see within these patients with thyroid nodules is hypervascularity. This also increases your risk of malignancy. And in this case, you can actually, the hypervascularity is extending out of the capsule of the thyroid. And this was confirmed on later operative intervention to be invading into the strap muscles. So what do we do in the office to evaluate these more suspicious lesions of malignancy? Obviously, we're going to be performing ultrasound, but we use it now to perform an FNA biopsy. So here I'm demonstrating how this is done. We do this quite often with Dr. Aurora out in her clinic in Elmhurst. You usually use the longitudinal view to insert a needle into the nodule that we're looking for, passing it a couple times, aspirating as we pull out. And this is a quick, easy, safe procedure. So how good are we at diagnosing thyroid cancer, and how good is the surgeon-performed ultrasound as compared to a pre-consultation ultrasound? This is a recent study out of the Medical University of South Carolina. They looked at 136 consecutive patients. They had surgeon-performed ultrasound and a pre-consultation ultrasound by a radiologist. And they looked at whether the surgeon-performed ultrasound changed management. In this, they were able to show that the pre-consultation ultrasound failed to mention node status within 74% of patients. It failed to show bilateral thyroid nodules within 26% of patients. Local invasion in 100% of the patients was missed by the pre-consultation ultrasound. And overall, surgeon-performed ultrasound changed the operative management in over 45% of the cases. So continuing on, just wanted to briefly go over the parathyroid, which we do. I think this is integral to our training. I just had a case with Dr. Aurora 2 weeks ago at Elmhurst where we're performing a total parathyroidectomy in a patient with secondary hyperparathyroidism, where we brought the patient to the operating room, scanned the neck in the operating room. We're able to identify all 4 glands. Then we were able to enter the neck with the game plan. We knew where we were going, we knew what we were going to find, and it was an integral part of the operation. So what are the characteristics of a parathyroid adenoma? They're hypoechogenic, solid nodules. Calcifications within them are rare. They can have cystic components, and they're usually multiple and small. And 90% of them show hypervascularity. So let's look at some of these. This is a typical parathyroid adenoma seen behind the thyroid. You see a hypoechoic solid with a slight cystic component here. And indeed, this is another image showing a parathyroid adenoma, which shows increased uptake or increased vascularity on color imaging. So how good are surgeons at looking for parathyroid adenomas? If you actually look at this study out of Duke, it looked at the results of 516 patients over a 10-year period, comparing surgeon-performed ultrasound to sestamibi scanning. And if you look at the sensitivity for the surgeon-performed ultrasound, it was 91%. If you looked at sestamibi scanning, it's only 76%. And we can keep going. This is another study of 200 patients with hyperparathyroidism that underwent surgeon-performed ultrasound imaging in the office. And based upon their findings, a clearly identified adenoma in the office can lead to a focused, limited exploration and avoid further imaging 93% of the time. And just to beat a dead horse, this is another study out of Rush looking at surgeon-performed ultrasound in 226 patients. They found that surgeon-performed ultrasound was more convenient, less expensive, with a nuclear test costing about $1,300 and a surgeon-performed ultrasound costing $200. They were able to localize in 77% of these cases, and they only used additional studies when the surgeon couldn't identify the offending adenoma. And their recommendation is that surgeon-performed ultrasound should be the initial localizing study when evaluating a patient with primary hyperparathyroidism. So now let's move on. We're moving in on a half hour, so let's keep moving to one of my favorite exams. This is a recent case that we had out at Elmhurst again. This is a 56-year-old male. He came in with abdominal pain for 5 days. He's got a white count of 18. The ED is calling you about this patient. They're saying he's extremely tender. Do we believe them? I don't know. They want to get a CAT scan. So they're calling us. They're asking us about this. What do we do? Do we go see the patient? Or are we just waiting on a CAT scan? No, we go down and see the patient. You go down, you examine the patient. His tenderness is not what they're describing. He's tender in the right upper quadrant. You go over, you grab the ultrasound, you put the probe on him, and this is what you see. You see gallstones, you see thickening of his gallbladder, you see pericholecystic fluid. Do you still want to get your CAT scan? No, we admitted this patient, we gave him antibiotics, and he's getting his gallbladder removed. So when I perform gallbladder ultrasound, I think of 5 questions. Are there stones? Is there a sonographic Murphy sign? Is the common bile duct dilated? Is the wall thickened? And is there pericholecystic fluid? So here's a nice image of a normal gallbladder. No stones, no thickening. It's beautiful. Nothing like we ever really see. Here, you can obviously see the stones. They have their characteristic finding of echogenic stones within the gallbladder causing their characteristic shadowing. Can we only see stones? No, we also see sludge. Here's an imaging showing sludge within the gallbladder. And then finally, cholecystitis. This is a patient with cholecystitis. You can see multiple stones, pericholecystic fluid, and a thickened gallbladder, distended gallbladder. And this patient also had a positive sonographic Murphy sign, which is elicited by pushing down directly over the gallbladder with your ultrasound probe. So what about looking for the common bile duct? This is actually often difficult to examine, and I find it very difficult to find. The best way I found is you get a longitudinal view of the gallbladder, and you get the portal vein right behind it, and so it almost forms an exclamation point. In this view, you can scan back and forth, and you can look for the 2 bright hyperechoic walls of the common bile duct. And here's a nice place for you to identify it and be able to measure it at this point. So to answer the first question, stones or no stones, are surgeons good at being able to identify stones? In this meta-analysis looking at over 1,019 patients, surgeon-performed ultrasound had a 96% sensitivity for identifying gallstones and a specificity of 99%. What about the accuracy of surgeons performing gallbladder ultrasound in the setting of cholecystitis and comparing that to radiologists? In this study of over 200 patients with pathological confirmation of cholecystitis, the sensitivity for surgeon-performed ultrasound was 84.2% compared to radiologists of 92.3%. And there was no difference between the two as far as significance. So I'd like to move on from here. Let's go over another study, which is basically my favorite and the one that I've actually got most of the satisfaction from in performing. So let's say we start with a 33-year-old female. She presents to the ED. She has no past medical history. She has 1 day of abdominal pain. This time you have a very zealous ED physician, and they come up to you and they say, look at this. This is what I found. And you're looking at it and looking at it, checking it out. You're like, what am I looking at? And so what do you want to do with that? What's your interpretation of this? What's your plan? Let's look at it again. What if I told you this is the structure we're looking at? This is a tubular structure. It's in the right lower quadrant. It's going down. It's blind ending. It looks dilated. When you push on this area, the patient has a lot of pain there. Their white count's 11. What do you want to do? So this patient, yeah. So this patient had appendicitis, taken to the operating room, had an appendectomy. So I want to review the anatomy, and this illustration shows what I look for every time. This is kind of my home base when performing ultrasound of the right lower quadrant. You can see the iliac vessels here, the psoas lateral to it, and this is where a spot you can go back to every time, and I consider this home base. Go back. If you get lost looking in the right lower quadrant, you can go back to there. What does this look like on ultrasound imaging? Here you go. You can see your iliac vessels, the psoas, and here you can actually see a normal appendix passing over it. So how do we perform ultrasound for appendicitis? Usually we're using a linear high-frequency probe, and we place it in the right lower quadrant, and I like to start with home base. Oftentimes what I find is I actually just hand the ultrasound to the patient and say, here, where do you have pain? And they put it, and then they show me their appendix. So what is the criterion we use? 6 millimeters. It's blind ending. There's no color flow. It's non-compressible. There's pain with compression, and there's no peristalsis within it. So let's look at these. Here's an appendix measuring here to 1.36 centimeters in size. Definitely meets size criterion greater than 6 millimeters. This one, you can basically see the finger of the appendix. You can see it's blind ending. Continuing on, you can place color flow on to make sure you're not looking at a vessel. So here you can see a tubular structure in the right lower quadrant overlying the iliacs. You can see flow within the vessels and maybe some peripheral enhancement in the appendix, but there's no color flow in it. And then finally, compressibility. This is important because you could look at this image here and you can say, hey, that looks like an appendix. But with compression, you see it flattens out. And this is a common mistake I see, is mistaking the ileum for the appendix. Another important thing to look at, like I said, is peristalsis. If you look at the small bowel long enough, it's going to start peristalsing, and the appendix really doesn't do that. What else can you look for? You can look for abscess. Here's a patient with appendicitis with a large periappendiceal abscess. You can look for free fluid. Here's a large amount of free fluid next to the appendix in a patient with perforated appendicitis. So what's the evidence? What's the sensitivity for ultrasound? So really it depends on the study you're looking at, ranging from 72 to 95%. So why is there such a big difference? There's actually many factors. One of them is, was this study done in America? Was it done in Europe? Europeans, like I said, have been doing this longer than us, and they do it much more often than us, so they're better at it than us. What kind of machine were they using? Is this an older study using poor quality machine? Also, is this an obese patient? Definitely, obese patients are not the best patient to be performing ultrasound on. It's very difficult, and you can't visualize the appendix well in these patients. And then finally, this is always operator dependent. So which chief do you want performing? So looking over the literature, you can look at the review looking at the best American literature for appendicitis, showing a sensitivity of about 86%. Comparing this to recent European literature, showing a sensitivity of 92%. This is performed by radiologists. So this is actually an interesting Dutch study that looked at a new algorithm for patients coming in with suspected appendicitis. They evaluated every patient that came to the ED by a surgeon. They came down and evaluated the patient and then decided to send the patient off for imaging. They used an ultrasound first approach, and if the ultrasound was negative, they continued on with CT. They found that using this algorithm, the ratio of ultrasound to CT was about 6:1 overall and 24:1 in children. The sensitivity and specificity for ultrasound were 91% and 98% for ultrasonography, and the sensitivity and specificity for a CT is the best, though. It's 100%. So how good are surgeons? Those were radiologists looking. How good are surgeons at performing bedside ultrasound for diagnosis of appendicitis? In this meta-analysis of 8 studies, looking at over 1,200 patients, surgeon sensitivity was about 92%. So here's a cartoon. Often we ask what the appendix does around here and we remove it. So going back to my original slide, obviously there are a lot of studies that the surgeon can perform and should be familiar with. So I hope maybe I've inspired some of you to pick up a probe and start scanning. Thank you very much. Do you have any questions?